Welcome to ESC Snacks, here live from ESC Congress 2025 in Madrid. It's my great pleasure to have two brilliant colleagues here together to talk about Hotline 6. It's Professor Alaide Chieffo, EAPCI President from Milan in Italy, and it's my dear friend and colleague Dr. Mirvat Alasnag from Jeddah in Saudi Arabia. So let's directly deep dive into Hotline 6. So Alaide, do you want to comment on SweetPad 1 and 2?
Yes, I had the privilege to co-chair this session with Robert Byrne. It was a great session, very interesting late-breaking clinical trial. And the SweetPad 1 and 2 was interesting. There was a lot of expectation of them. So this was addressing the population on peripheral artery disease from more advanced stage of limb ischemia in the SweetPad 1 that enrolled around 2,000 patients. And the primary endpoint was regarding the amputation, and it was not met. So there was no advantage in using drug-coating balloon with paclitaxel as compared with the control group on this primary endpoint. However, there was an advantage in reducing the rate of reintervention. The second indeed was addressing patients who had claudicatio intermittens. And in this case, the primary endpoint was the quality of life on the claudicatio intermittens. And again, this was not met. And there was even some signal for mortality higher in drug-coating balloon at 5 years that was not confirmed at 7.
Okay. Thank you for summing it up. So what is your takeaway for clinical practice from SweetPad 1 and 2?
The takeaway is that there is no advantage, but we have to take into account that all the DCB technology with paclitaxel were included, and we know there are differences in technology. And also it was a very long time of enrollment, and there is also difference in expertise of the operator, and now this procedure is done.
Okay, thank you very much. So this session was a whole wrap-up of different things. So let's talk on the aquatic trial. Mirvat, do you want to comment on aquatic briefly? What was aquatic about and what did it show?
So aquatic addressed a very important clinical question that we all see in practice. It was a well-conducted trial. It was double-blind, randomized trial that looked at patients with chronic coronary syndrome who had high ischemic risk because they actually had complex coronary disease, but also required oral anticoagulation. The majority of them were on NOACs, and less than 10% were actually on VKA antagonists. And they looked at, after 6 months, they were randomized into keeping aspirin with the oral anticoagulation versus placebo with the oral anticoagulation. And they looked at hard endpoints that we want to look at. And, they ended up enrolling, this study was terminated prematurely because the Data Safety Monitoring Board actually noted the signal of increased adverse events in the patients who continued to have aspirin. And so they ended up enrolling only 870 plus patients here. And when you looked at the primary efficacy endpoint, there was no advantage to having aspirin. In fact, if anything, the bleeding rates and consequently the death rates were actually increased in this population, which really tells us now that we shouldn't, at the end of 6 months, be adding aspirin. But it's a complex issue when it comes to this.
Yeah.
Really.
So there seems to be not an additional benefit from adding a single antiplatelet therapy through oral anticoagulation. Important message. So the last one, and I'm eager to know your both opinions on this, is the Option STEMI trial. So Alaide, would you briefly sum up what Option STEMI is about?
Yes, that's another very interesting trial. It was conducted on an Asian population, by the way, and this was a randomized clinical trial regarding the topic of when you have to complete the revascularization in the setting of ST elevation MI. And the whole point was if you have to do immediate versus before the hospital discharge. So there was a conclusion regarding non-inferiority, regarding the immediate versus the one before the hospital discharge. There were some interesting findings regarding, for example, the fact that in a specific population which were more advanced KILIP class, there was not the advantage to do an immediate revascularization. So clearly is important the patient selection. So the patient, we have to say that were excluded the classic SCAI C shock. But as you know, I mean, you can have a patient with a SCAI A and B that is mostly or anterior large MI, and maybe in this subset of the patient, you have to take into account if it's a complex patient population that you have not to do it all at one time, because this was this signal that I think it was very interesting.
Okay, still not a closed book, I think, when to do the procedure in multivessel disease and in STEMI, or what is your takeaway, Mirvat?
So I think just as Alaide said, so at 1 year when they looked at the primary endpoint, which was a composite of all-cause death, unplanned revascularization, and non-fatal MI, it did not meet the non-inferiority mark for it. So, you know, there's no pressing urge to actually do complete revascularization during the index PCI, as opposed to staging it, and perhaps now, as you know, guidelines and heart teams need to decide whether the staged procedure needs to be done during the index procedure or subsequently. We know from the complete trial, you know, you have room and you can discharge the patient home and bring them back. Perhaps we have to juxtapose this to the BioVasc trial and the rest of them. But these trials, we need to tease the details, because, you know, I would be inclined to stage somebody with complex bifurcation, for example, and not do it right away. And so the procedural details and the syntax
Also
score are
matter.
also important,
Yeah, of course.
in addition to the KILIP score.
Doing a DK crush in the middle of the night, not experienced if you're starting your career and you're on call. So in my honest opinion, also needs to be staged. The timing of staging needs to be discussed. The guidelines are clear about this. I think it will not change the guidelines in the future. But let's see. Let's see. So thank you for attending this ESC Snack episode on Hotline 6. Stay eager. Go on EC365 to watch more content, and see you soon. Bye-bye.